All right, good afternoon. We're so thankful for you to join us at the December MCHRI monthly seminar series. Again, this is the seminar series which is designed to focus and highlight key programs of maternal and child health around the university. And today we have an amazing program of highlighting the Global Child Health Program on campus. But first, a couple of housekeeping piece of information for you. Next slide, please. Besides today, I really just wanted to highlight next month's MCHRI seminar series topic, which is research in the real world, reducing disparities in our backyard. I really want you to really focus on this and to join us for this, because really it's a highlight of community-based participatory research in the Bay Area with 4 amazing experts, including listed here, really trying to reduce disparities in our backyard. Today, and then also just remind you, up next October 22nd, put a 20th on your calendar, the 5th annual Maternal and Child Health Research Institute Symposium. I know that we just finished one last month, but put this Thursday, October 20th on your calendar, likely to be in person as well. So that's pretty exciting. And next, also just wanted to highlight the Drive in Research Pipeline mentorship program for interested undergraduate students. This program is a unique program for undergraduate research mentorships for those in this upcoming summer of 2022. Please check the Drive website if you're interested and qualify. We have a number of outstanding mentors waiting for qualified students to join their lab. So please apply. The deadline is January 31st. So write your application over the break. And just again, to thank the MCHRI Education Committee shown here, who put together the symposium and the seminar series to highlight the outstanding work that's going on. But today I wanted to really, we're going to highlight the Global Child Health Program, and really led by Dr. Michele Berry. Dr. Berry is the Schenz Professor, Senior Associate Dean for Global Health, and the Director of Innovation for Global Health, and really has, well, her interests has spanned both medicine and both adult and children. Since coming from Yale, she's really partnered with the MCHRI for many years to develop innovative solutions for global health, and which is the focus of today's seminar. I'm really excited about the seminar and the group that she'll introduce. So I won't waste any time to hand it over to Dr. Berry. Dr. Berry?
Thank you, Anthony, and thank you for that kind introduction. It's my pleasure to be here with you today to celebrate the remarkable work being done at Stanford to actually advance the health of children everywhere. And the Center for Innovation in Global Health is very grateful for the Maternal Child Health Research Institute's support to our seed grant program in global health. This gathering is timely. Over the last 2 years, we have seen the twin pandemic of COVID-19 and climate change pose significant challenges for maternal and child health worldwide. Here are just a few of the concerning statistics we have seen during these 2 pandemics. Children have suffered emotional trauma and lost learning during the pandemic across the globe. They've also lost access to preventive health care. Between the start of the pandemic and when health services began to recover in the second half of 2020, more than 30 million children around the world missed their vaccinations. That's 10 million more before the pandemic. A recent WHO CDC report found that measles outbreaks may be more likely in the near future after the number of infants missing their first vaccination jumped by 3 million last year, the largest increase in 20 years. At the same time, and particularly in California, we've seen increasing extreme weather events, such as wildfire, heat waves, drought, to which young children are more susceptible than adults. These events also increase the risk for preterm births. Pregnant women's risk of depression has also doubled during the pandemic. This was a Stanford-led study that found these statistics, and they're deeply troubling. But last year has also contained some bright spots. innovations that were made to meet the challenges in advanced maternal and child health. For instance, the Pfizer vaccine is now available to children ages 5 and older, thanks in large part to the efforts of Stanford researchers working with Global Child Health Program, including Dr. Bonnie Maldonado. Healthcare providers have found innovative ways to support pregnant women, from prenatal telehealth appointments to virtual doula care and to self-advocacy training. These adaptations make these critical supports more accessible to all. For the first time, WHO is recommending widespread, and this is very big news, of a malaria vaccine among children in sub-Saharan Africa. This is really the first vaccine for a parasitic disease, and in other regions with moderate to high malaria transmission. This is the potential to help save the lives of tens of thousands of young children each year. Our own team at CIGH, the Center for Innovation and Global Health, is working with pediatricians at the Sean Parker Center for Allergy and Asthma Research to find ways to make community resilience hubs. These are actually hubs where children and family can find refuge from heat, poor air quality, and other impacts of climate change. Clearly, the need for innovative life-saving solutions like this has never been greater. And that's why I'm thrilled to be here today, because it's really the work of Stanford's Maternal Child and Health Research Institute and the Global Child Health Program, which has helped to develop our next generation of physician leaders. Stanford's Global Child Health Program works to improve the health and well-being of children around the world through medical training, multidisciplinary research, and improved clinical care for the underserved. We have a Mary Duke Biddle scholarship program, now known as Stanford Global Health Travel Fellowships, and dozens of medical students, residents, and faculty scholars annually receive clinical training overseas in 14 different countries in Asia, Africa, and Latin America. I'd like to take a moment to acknowledge the wonderful team, Bonnie, Dr. Clea Sarnquist, Dr. Gary Darmstadt, Dr. Desiree Lebeau, Jenny Kang, and Rasika Bell for actually administrating this amazing program in child health. But for the past 9 years, the center and MCHRI have partnered to kickstart early stage research projects through our global health seed grants. These grants help bring innovative ideas of Stanford's talented researchers, of which you're going to hear from 3 today, to fruition, building much needed bridges between wide-ranging, and they're wild also, disciplines. We're so grateful for MCHRI support, and without it, this life-saving research that targets the overlooked and marginalized populations around the world would not be possible. You'll hear about some of this life-saving work today. Our MCHRI seed grant recipient, Pascaline Dupas, has been working to improve the quality of public health care in rural Côte d'Ivoire at the Ivory Coast through community participation. Lambertus Hesselink, another seed grant recipient, will share how his team designed a new pediatric ear, nose, throat diagnostic tool, the nasoendoscope, that is far more affordable than the existing models, while also being more comfortable for young patients. And he'll be joined by one of his students, Anna. I'm looking forward to learning from these researchers alongside you. I'd like to see the progress that our seed grants have made, and I thank them for joining us. First up is Dr. Lambertus Hesselink, Professor of Electrical Engineering and by courtesy of Applied Physics. One of the things that I'm very proud of for our seed grant programs is that we really draw from all 7 of the schools at Stanford. Bert, I'll hand it off to you.
Thank you, Michelle.
You want to share your screen with us? Thank you.
Okay, can you see my screen?
Mm-hmm.
Well, thank you, Michelle. It is a great pleasure for me to talk to you about this project, but I've been at Stanford for quite some time, and I would say that the biggest pleasure I get out of working at Stanford is teaching and working with incredibly interesting students. And this is an example of a project where really the students were driving it more than I did. They came to me with an idea and said, could I please help them on an endoscope? And my background is in physics and optics, and I've been teaching a lot of courses at Stanford. And I said, yeah, of course. And so Anna von Wendorf, who is going to give part of the talk here, essentially has been leading this effort with two other students. And I have to say, this has been an incredible, interesting collaboration with her, and she should really, and her team, get most of the credit for this work. So the basic idea is how do you actually build a nasoendoscope that is affordable? And so the first thing you might ask is, is there really a reason to do that? And it turns out that roughly half of the pediatric consultations are essentially associated with problems in the nasal cavity. And this could be things that, are associated with inflammation, or maybe some polyps that would occur, and maybe some anatomical variations and neoplasm. And the basic thought is, how do you actually figure that out? Could you use either optics or some other means of doing that? And since this is a pretty important problem, and there's roughly like 21 million of these visits that occur in the United States every year, you would think that there would be a good solution for it, but there really isn't. And so the real challenge, I think, what the students were trying to attack was, can we actually build a nasal endoscope that would not cost $60,000 or $100,000? And the answer turned out to be yes. And so I worked with them because I taught a course also on on lens designs, where a number of other students actually worked on endoscopes. And so we've made some pretty interesting optical devices. So the first thought was, well, maybe we should make it kind of based on a optical design where you have a lot of optics that take the object and image it and then turn it into an electronic data set. So the competition is very expensive. From Pentax, you can get two of these nasal endoscopes anywhere from $60,000 to $100,000. And there are some problems because of the fact that you actually have to put them in the nasal cavity. There's cross contamination, and so decontaminating is a significant issue. And then it takes time and money to do that. And this also is a very high upfront cost. And so when you have the idea that you really want to work with children around the world, then 60 to 100K is an unsurmountable barrier. So given that that was the marketplace, the design that ultimately was taken was an extremely simple approach. So what you see here is kind of a handheld device. And instead of having a lot of optics inside this device, like, for example, is the case in your scanner that you see in the grocery store, where the optics is taking the object and putting it onto a camera at the back of the device. In this particular case, the design that the team came up with was to use a flexible tip. And then because of the availability of very small detectors and light sources, those could actually be put onto the tip. And now you turn that optical image into an electronic data set, which you then can send out to a computer that is connected to it. But now it's a handheld device with very few components. And it's very easy to take the tip itself and disconnect it from the rest of the scanner. And so that allows it to very simple to replace them or disinfect it. And then the usage of it is extremely simple. You don't need to have a lot of education to do that. And then you can hook it up to already existing devices that are maybe available in the doctor's office. So it's plug and play and making that simple. The final slide that I'm going to talk about, and then Anna is going to take over, is how good is this device? And I have had a lot of experience working at Western Digital, where we sold hard drives. There's a price point that you can sell a lot of devices, and if you're much above it, you sell none. And so 60 to 100K is obviously way too high. So the BOM cost here, the cost for the components is on the order of about 352. The assembly you get 420. So we essentially are like 5% of what a typical machine would cost. And I think that will induce, on my experience at least, an enormous interest in it. And we from studies learned that 95% from the PCPs are willing to use it if it's simple and low cost. So I think this could have a very significant impact on how these nasal problems are being addressed around the world. And so the fundamental design process was make it simple, make it cheap, use off-the-shelf components, and then make sure that you can actually use it, clean it, disinfect it, very little repair because it's so simple and maybe just on a replacement basis. And so then use it in many different areas where you can. So that was part of the technology part of it. And then Anna is going to talk about how she tested this and what the outcome of that is. So Anna, do you want to take over here?
Yeah, thank you so much, Professor Hesselink. So 2/3 of our grant portion was really the development of the bill of materials and figuring out who our contract manufacturers and assemblers would be. And then the remaining 1/3 was really setting about making sure that that prototype fit within the minimum specifications that it needed to. And we did that on 3 main fronts: the ergonomics and making sure it was comfortable with the users, the optical specifications, both on the hardware and the software side, and then also the anatomical identification and just the fact that it would fit inside of the patient as it needed to. And a couple key things that came out of there on the optical side was the fact that, as Professor Hesselink mentioned, we were able to purchase optical setups without needing to assemble them ourselves, which really increased and increased the reliability of our setup and the manufacturing process. And it actually decreased a huge amount the amount of image processing algorithms that we needed to take. And you can see with one algorithm on the left-hand side, the effect that that would have. And so that's pretty amazing that we didn't need so much of a complex image processing system. And the other major thing that we did most recently with a grant from the National Science Foundation was talking to users in the United States and primary care practitioners and having them hold the device and see what it would feel like and how different it would be now that they, for the first time, have a specified grip and a place to hold this device, which they don't have in their current systems. So if we go on to the next slide, we can also see that one of the things that came up again and again was the ability for software to create higher quality and the quantity of the diagnoses done by this device and the consultations. Because right now, a key reason that these consultations aren't done is not only the lack of the actual equipment, but the lack of the skill to do the diagnosis based on what you're seeing. And so the ability to record and send and share in a HIPAA compliant way the results of those diagnoses, of those consultations and those initial procedures really allows more people to get higher quality nasoendoscopic procedures than ever before. And so us being one of the only kind of ways of designing a nasal endoscope in a way that would really create a high quality database of nasal endoscope designs would really allow us to create more of an AI system and a way for the computer, not only a physical specialist, to act as that consultation. So we actually recently finished our high quality prototype. So if we go on to the next slide, you can see a little bit of next steps that we're working on. We feel very confident that the prototype performs to our specifications and is attractive to a broad customer group, both outside of the United States and in developing countries in particular and emerging economies, to specialists, and also in the United States to primary care practitioners like pediatricians who need a better way to do a posterior nasal endoscopy, but also an anterior in many cases as well. And so we just recently founded a company, and we are looking to bring this design to clinical use, bench to bedside, as they say, and have just started looking for investment for about 720,000 kind of cost hurdle that we have in order to complete our FDA 510K pathway for clinical approval to sell in the United States and around the world. So yeah, that's a little bit about our project, and thanks so much to Professor Hesselink and to MCHRI for all of the support that we had. We are really fortunate to get to this place, and we're really excited about making it a reality. Thank you.
Thank you.
Thank you.
Thank you, Anna and Bert. I think this is a great example how a small, modest seed grant and a brilliant student with great mentorship can really bring a tool that's so important for a very low cost. And I really congratulate. I hadn't heard that you were putting it in actually developing a company or, scaling this up. So that's great news. Next, we'll hear from Dr. Pascaline Dupas, the Klein-Heinz Family Professor of International Studies, Professor of Economics. She's also the faculty director of a really wonderful center called the Stanford King Center on Global Development. She's a senior fellow at SIEPR, which is the Stanford Institute for Economic Policy Research. And she's also a senior fellow at Freeman Spogli Institute for International Studies. Pascaline, can you start sharing your screen?
I'll do. Thank you so much for this very nice introduction. Here is my presentation. All right, so I'll transport you to a very different context than the one we've just heard about. We're going to be thinking about the management of healthcare facilities in rural Côte d'Ivoire. And we are very grateful to the funding that we got for this project. Part of the funding came from the ULED Foundation, which was supporting the postdoc position of Marie-Christelle Apedoama, who was a postdoc here at Stanford for 2 years. She's now moved on to the World Bank. The background work previous to this research was done through that postdoc fellowship. And then while we were researching these issues, we came up with some idea that then we got very lucky to get some financing from at the seed level from the Center for Innovation in Global Health and the Maternal and Child Health Research Institute. And we collaborated on this research with Yaoundé, who is from CARE Côte d'Ivoire, an NGO that helped us get everything done on the ground. So just to give you a sense of why we decided that focusing on community management of healthcare facilities in Côte d'Ivoire made any sense, I just wanted to start with some background. Côte d'Ivoire is not doing that great in terms of providing effective essential health services. This is, a chart put together by IHME, looking at the progress in terms of providing this, basic health services in Côte d'Ivoire in the past 30 years. And you can see that there has been progress from, 26.5% effectiveness, whatever that means, to 43%. Sometimes it's hard to think about what these numbers, really should reflect. So I put here some comparison for you. This is pretty much the level of Sierra Leone. Okay, so Côte d'Ivoire is in many ways, doing better economically than Sierra Leone, but it also went through, a period of civil conflict, and so its health system is somewhat behind what it could be given its economic, power. And also as comparison, Côte d'Ivoire is behind Ethiopia at 46%, Ghana and Kenya context you may be more familiar with at 50%, Rwanda, many folks from the MCHRI community working in Rwanda, and Mexico around 60%, Brazil 65%, and just so that you know what the economic end goal is, the US is only at 80%, on par with Costa Rica. And maybe the frontier, if you will, would be big countries like Sweden or France, randomly chosen, at 90%. So this is just to give you a sense of how there's still a lot of room for improvements in the delivery of basic health services. And you can see that also when you look at child mortality, one of the easiest metrics to track. You can see there's been a lot of progress in Côte d'Ivoire, in the last 20 years, but we are still far from where things could be, with under 1 mortality as still very high, 50 deaths per 1,000. That's about 5%, and under 5 mortality at close to 7%. Okay. So where do these deaths come from? Again, this chart from the IFME suggests that malaria is still the primary cause of death, and neonatal disorders are also a very important cause of death. The second cause of death, lower respiratory infections, diarrheal disease is number 7, tuberculosis. So a lot of these things that we know how to deal with if they are brought through the facility seem to be causing death. And so this raises a question of how can we make the delivery of these basic services that we know can be effective at saving lives be delivered. And there's been a big push over the past 15 years to really give power to the people, as you can think of it, which is to say, well, it's really the very poor in low-income countries that seem to be failed by healthcare delivery. Sometimes there's just a problem of stock. The health facilities don't have on hand what they should have, or the health staff is not showing up as much as they should, or they don't seem to have the right training. They don't seem to be monitored enough. There are long waits, and that discourages people to even show up. And so you have this vicious circle where people don't show up for care because they don't believe they're going to get proper care. And so health workers are like, well, what should I even show up if people don't show up? And so how to break that cycle? People have said, well, ultimately the end users are really the ones who should be empowered to participate in the management and the monitoring of health services because they have the most at stakes. Okay, and so if they know what they should get and they know what's feasible, they can kind of put their foot down and say, we deserve these services. Now, a lot of assumptions go behind the theory of change. In particular, there is this idea that a poor mother is going to be able to by mere virtue of saying I should get the service, be able to get it. And so it's sometimes quite unclear whether it's really a potent idea, this idea that end users have the most at stakes, and so we can harness their will to get better care. It may be very tricky to tell your health worker, well, you're not doing a good job. I expect more from you. And in fact, there's not been that many rigorous evaluations of this type of initiative that really try to empower people. And whatever evidence we have is kind of mixed. And the evidence that suggests that you can successfully empower people to get better care come from programs that are extremely expensive to do. They require a lot of training, a lot of in-person support, a lot of hand-holding for a very long time. And so it's not typically scalable. So what we decided to do was to try something much cheaper, more easily scalable, something that's kind of sustainable in terms of requiring less time of everyone, and try to see whether we can help take advantage of end users' interest in getting better care in a way that's may sort of deal with all these issues. And so we did that in rural Côte d'Ivoire, where on paper you have local community organizations supposed to be overseeing healthcare facilities. They are called COGES, which is an acronym for a French term I won't spare you. And it's COGES, when we went there in 2018, we found that most of them were dysfunctional. They did not meet. There was on paper a president and community members, but part of it, but there was really not much going on at all, and they were not even sure what their role was, and they received absolutely no support from the healthcare administration. So they said they wanted to report a grievance to the district level to say, well, the in charge of this health facility is not doesn't seem to be performing. They had no way to directly reach out to the district level to get someone to listen to their grievance, and so it seemed like they essentially gave up and nothing was happening. So with our team here at Stanford, with our seed funding, reached out to the Ministry of Health in Côte d'Ivoire, and work with CARE Côte d'Ivoire in order to pilot a program which was trying to recreate management committees for the local health facilities that would be, more inclusive, and in particular that would bring in more women and youth, since women and their children are the primary users of these local primary healthcare facilities. And young women in particular, who are the ones who have, who are giving birth. And once we had, recreated these management committees in a more inclusive fashion and trained them, we provided coaching, through regular phone conferences. So instead of having, a very, heavy-handed one, NGO on the ground being there near the health facility, for a long period of time, handling one community at a time, we had kind of like this remote coaching, if you will, through the phone, which can be scaled up much more easily. And really the goal was to improve healthcare access and quality. So the context is really one of very rural health, primary healthcare facilities. I put some pictures here so that you get an idea. We are not talking any, super fancy things here. There's really basic facilities where you can go get, basic prenatal care, get your vaccination for the kids, get, treated if there is a bout of malaria or something else. This is the type of posters that you can see in the clinic telling you, all the calendar. This is the calendar for all the vaccines that kids are supposed to be getting. As you can see, this calendar has not been refreshed, particularly recently. It's a relatively low-key technological environment. And the idea was through this program that we call REACH, for Remote Assistance and Coaching Helpline. We first train communities and make it more inclusive, and then provide this remote coaching over the phone for a year. Okay, and the idea is to get to a system where these community management committees are somewhat effective and able to hold their health workers more accountable, and also help them with getting better services from the district level. Okay. So making the health workers and the community kind of like partners in getting the administration at the higher level to be more responsive to requests. And if there are some, let's say, stock shortages that come from the district level not doing their job, then putting pressure that way. So ultimately, the goal is really to improve health outcomes, but through this improved management. And so there were 3 steps in the delivery of the program. The first one was to meet with the entire village community and encouraging people to step forward and join this COGES, this management committee for the health facility. And then we had 2 versions of that to be able to look at the role specifically of including women. We had a variant where we didn't put any constraints on who could be a member of the COGES. And we had a second variant where we very strongly encouraged women to join and to take on leadership roles. So it was kind of like soft quotas. We didn't like really impose this, but we made it sound like we were going to be, that we really thought it would make sense to have at least half women, if not more, and that the leadership roles should also be gender inclusive. And then the second step was to train the members of the COGES over 2 days and to have them put together an action plan, as you can see from this picture here, thinking, okay, what are the main issues that need to be taken care of? How can we take care of them? What are the steps who should be responsible? If financing is needed, how do we get to generate income for the facility? Things like that. And then the third step was this like bi-monthly phone check-ins by reachers. These folks were sitting, in a central place, hired, to start with by the NGO CARE Côte d'Ivoire. And there was one reacher for about 20 or so health facilities, or 20 COGES. And their role would be, to call the members of the COGES, requiring all the members of the COGES to be there together to join this conference call every 2 weeks, and to share the struggle that they're facing and get tips and advice during that phone call. Okay, so obviously not every health facility had a landline. In fact, most of them did not. And so we provided, as part of the project, cell phones for the community, the management committees to be able to communicate with the reachers. And so the design was a randomized control design where we had 72 villages spread across 14 health districts, and we randomly assigned them to one of 3 groups. We have this, REACH program, just without any quotas on participation. We have the version where, if you did a typo, there should be 23 here. So 26 villages received the REACH program, 23 villages received the REACH program with this gender emphasis, gender inclusiveness component, and then 23 villages are control. We did the village meetings and the trainings in the fall 2019, and then the year-long support by the REACH program was until the end of 2020. And then we had scheduled the follow-up survey for the spring 2021. I mean, as you can imagine, this was, hindered by COVID. So we did, we did phone surveys only. We are not able to do household surveys. We were hoping to look at administrative data, to look at utilization, but it's going to be very tricky for us to look at the health outcomes. Okay, so that's one of the downside here. We are not able to go all the way down to health outcomes because measurement was compromised by the difficulties to field work in the context of a pandemic. So what are the results? On the process side, there was a process evaluation conducted by our partner CARE, and the researchers, these folks were calling the COGES regularly to check on them. They reported that 51% of the management committees that were treated, they quoted them as high performing. So that means that in their bi-monthly phone conferences with them, they felt like a lot was going on and were doing well. They were on top of things and really acting as they should. They rated another 34% as functioning, so not high performing, but as somewhat functioning, and the remaining 15% as non-performing. Okay, so that's the program did not succeed at getting all of the health facility to have a fully functioning committee. And then the CARE collective also conducted in-depth visits in 23 villages across health districts and reported very high satisfaction with the program overall. And some some progress on trying to get some formal financial management happening. Maybe not as much as was expected, but they estimated that 41% of the management committee at least had a dedicated accountant and books were well kept and things like that. Okay, so definitely not 100%. Not even 50%, maybe just over over a third essentially were able to get there. So what we did as the Stanford team, we focused on the impact evaluation more than the process evaluation, which means comparing the control to the treated to the control, and we're going to be focusing on the facility management aspect, which is what we could measure through phone surveys under COVID. It turned out that the administrative data on utilization that we obtained from the Ministry of Health is extremely difficult to utilize and not very helpful. So we're actually trying to work with the ministry to also help them rethink how to collect data that can be better used to truly measure performance, because the way it is right now, even though it's part of a performance-based financing scheme, we don't think it actually picks up performance at all. And as I said, we're not able to measure health outcomes. So with apologies for the fact that we are only going to be able to look at the management of facility, what do we find? Well, first you can say, well, did we succeed at changing, how active the COGES is and its membership? And here the answer is yes. So I'm showing you here the average number of active members as part of the committee. In the control facilities is about 6, and we have on average, 2.5 to 4 additional active members when we treated the COGES, so in the facilities where we implemented the program. And in fact, the effect is bigger when we had a gender inclusive component. And then when we look at active female members, on average, if you just do the basic program, you get 1 more active female member. If you do the inclusive program, we get 2.4 more compared to the control, okay? And the stars here indicate statistical significance. Now, looking at the impact on the facility management, we find that we asked, basic question to the president of the Women's Association in the village, so that someone who is not at all involved in the management of the community, not involved in the management of the facility, but someone who represents the point of view of women who are the primary end users of the facility. And we ask whether, there are like stocking problems, shortages and things like that. And here what I'm showing you is a positive outcome, which is the health center is well stocked. We find that only about 50% of the control facilities fall in that category. But when we implemented the program, there was a relatively large increase of 22 to 27 percentage points. Okay, that means that we go from about half of the facilities being well stocked to 3/4 of the facilities being well stocked when the program was implemented. And if anything, the effect is a bit larger when we have the gender inclusive component. Turning now to another question, which is absenteeism of the health worker. We asked, whether absenteeism is a problem, and that's something that we asked the president of the COGES to report. This is someone who is like in charge of actually paying attention to that and keeping track of absenteeism. And we find that here again, coding this as a positive outcome, if there's no problem of absenteeism, it's only in just over a third of the facilities that absenteeism is not a problem, which means that in 2/3 of the facilities it is a problem. But this share of facilities not having absenteeism as a problem increases quite a bit by 16 percentage points to over half when we did the program, the basic program, and further decreases. Further increases the positive outcome further increases when we do the gender inclusive component. Okay, so absenteeism essentially went down thanks to the program. This is another outcome, which is whether long wait times are a problem or not. So again, coding positive outcomes here. This is whether there's no long wait times for patients. And here again, we see an improvement on that metric. Here, in contrast with the previous results, the gender inclusive did not improve things as much, and it could be because the utilization increased more in the gender inclusive version. So if utilization increases more, even if absenteeism goes down by health workers, wait times may still be an issue a little bit. But as I said, the utilization data is unfortunately not utilizable. So I won't be able to test that, conjecture. And so finally, when we put all this together and we look at an index of performance, so we combine all of the measures of health facility management into one index, we find that this performance index, both versions of the program really improve the overall management of facilities, and more so if we did the gender inclusive version. Okay, so so these are all the exciting outcomes that we have. But if we look at another metric that we actually spent quite a bit of time training the coaches on, which was trying to help them increase the resources they have access to, in particular starting income generating activities for the health facility. Maybe have the community members join in creating some garden that are growing vegetables that they can sell to get resources to buy new machines for the facility. We didn't see any of that happening. And we also did not see any change in how much support the health facility seemed to be receiving from the health administration at the district level. Okay, so we didn't see more communication between the health facility and the district level. And it could be because on the one hand, when they have problems, they report them more, but then over time they have fewer problems, so they reach out less. But it doesn't, it's not clear that there was actually much going on at all. So after we stopped after 1 year and we did as design, the researchers were hired by the NGO, stopped making phone calls to the management committee, stopped providing that support, that remote coaching and support, and instead the phones were passed on to the district level, to the district office, health office. So they were the ones that were supposed to take over. They were the new point of contact, and they had staff that were supposed to be dedicated to doing this and being available for the committee, management committees to be able to reach out. Now, it's very unclear how much of that truly happened. In part, given the COVID disruption, clearly the health administration had other things on the top of their mind than this. So we are somewhat worried that it did not happen. We are hoping to be able to, give a ring to a bunch of our contacts to check and just ask them, did you ever get a phone call from the district, as they should have? But we're a bit worried it did not happen. Okay, so to conclude, we think it's kind of like a promising innovation. It's extremely cheap to do this, if you will, because it's just a matter of giving a ring to folks and checking, okay, how can I help you? Like, what type of issues can I give you some advice on, and making, giving the management committees a sense that somebody cares about them, is paying attention, and giving them some sort of like a commitment device to make progress from one phone call to the next. Okay, so it's very promising in terms of being cheap and potentially scalable, but for it to scale up successfully, you need a commitment from the health administration. You need the health administration to put in the time to actually continue doing that remote support. Again, unfortunately, given the context, we are not able to establish outcomes on health impacts, and so it would be nice to be able to try to replicate that in a context where it's easier to actually look at health outcomes down the road. So I'm going to stop here. Thank you so much for your time and attention.
Thank you, Pascaline. I don't know if everyone in the audience understands how difficult it is to work in the field and pull so much of this work together during not only the difficulty about being in the field, but doing it during COVID. So thanks for sharing. We do have a question. Mustafa, do you want to, I don't know, are they able to show their faces and talk on their own, or should I read the question?
Oh, why don't you go ahead and read the question, Michele?
I'm sorry, do you want me to read the question?
Yeah, go ahead.
Well, Mustafa Zahid asks, are there potential spillover effects on community well-being from having access to a phone while they had it? For example, being able to communicate their needs.
So that was part of the theory of change we had, was that having the phone will help. Sorry, I should take this back. Most people have their own personal phone. Okay, we gave a phone that was dedicated to the management committee, a phone that we knew we could call on a pre-specified time, and all the members of the management committee would be there together and do kind of like a conference call. And then that phone also had like essentially it was like think of it as a postpaid phone. And so they don't have to worry about having like money on the phone. They can use it anytime to call. And so our thought was that, yes, they can reach out to this, what we call the reachers, which are a dedicated team of experts helping them, but they can also reach out to the district level more easily. And in fact, we had, obviously we had set it up so that in case they felt like they were not getting, an ear in the district level, our experts were gonna help them and make that connection. And we didn't see that happen as much as we were hoping to. So that was a disappointing result, which is that it seemed like at the district level, they just didn't have either the time, the bandwidth to kind of like be more, available. And then it's kind of like a chicken and egg problem, because if you know that when you try to call, people don't pick up, or you're put on hold, and they say, well, we'll call you back, but then they don't call you back. After a while, you just give up and you don't try. So establishing that link seems to be very important, but we didn't quite get there.
Thank you.
I have a question. I thought it was amazing. Two amazing presentations, both from the two groups. I'm trying to develop cheap, deliverable, scalable help. The question I have more is for information technology, which is for Bert's the nasoscope. How can we deliver or assess or do AI images of the nasoscope in the field, so that then they'll be able to know what they're doing? And also for Pascaline, is the individual cell phone that everybody has in the Côte d'Ivoire accessible to delivering more information at a higher rate and more excitement? I mean, is there some way to do that on a more scalable level using whatever? I think the phone is probably what they have, right? So that's more of a general question, but maybe Bert, if you and Anna could chat about, because it's kind of a similar issue between that both talks have talked about, which is delivering IT help in the field.
Yeah, well, I'll start, and if Anna wants to add to it, that is true too. But so if you want to do AI, you essentially have to do a lot of training. And so that means you have to take a lot of examples, and then you have to decide what essentially you learn from those examples. So my view on this would be is that you start that in the area where you live, which means the US, and there you take advantage of a number of experts that essentially interpret these images. And then typically, at least my experience, I've been working in AI for some time, starting in 1990s. You need probably hundreds of thousands of images before you really can start bringing that error bar down. So my sense of it would be is as you start, you introduce this into the US, you work with physicians around the country, different places, you take lots of data. And then there's a number of algorithms that are already currently available that could be easily adopted to kind of make this kind of information workable, and then create an AI response to it. The question is, how much computing power do you ultimately need for that in order to be able to make it happen? I would envision that in the future, rather than hooking it up to already existing computers, you might consider kind of hooking it up to a cell phone. Cell phones have enormous amount of processing capability. And then if you do have it available in Africa or so, one thing that's happening right now is that the Starlink system, in fact, I bought this for my place up in the mountains. It's phenomenal. And so I envision that in Africa and so on, where this is going to become available, there will be an enormous increase in the ability to hook it up to the network. And so in that case, then you essentially have a central processor and work out the AI part there, and then you get the result back. But you would also have to integrate that with physicians that could help out. And it's not just only an automatic system that will do it. And so telemedicine has been developed for a long time. And in fact, I was in that field in the early 2000s. And so I think the pieces are coming together. And I think in the future, Scopy could do a great job there.
And maybe I can jump in really quickly just before Professor Dupas mentions her project. But the one thing that we found really difficult with the nasal endoscope is the amount of different diagnoses that we're doing. And so we really have to choose one. And for each one, there's a treatment algorithm or a diagnosis algorithm. And we're almost a level above the diagnosis algorithms that are out there. And so that's been really difficult. There's some beginning research that recently was published showing that if you show the same nasal endoscope recording to two specialists, about 50% of the time you'll get different diagnoses, which is, really difficult to train an AI to be perfect when perfection is unreachable in that sense. And to some extent, there's so many different things that you could find in a nasal cavity that it's almost like, yes, you could diagnose one right, but then how do you make sure that you're, not missing another one? And so that's what we've come across as difficult, not only in the kind of academic sense of the word, but also in the regulatory sense of the word, and really having to so strictly define for the FDA what we're doing, and the fact that we're not making the diagnosis, we're supporting the initial diagnosis. And that's a really difficult thing as we go through the design process itself.
So thanks for the question. So it is the fact that most people have a cell phone is indeed a very exciting opportunity to share information. Now the problem, if I may say, that well-intentioned public health officials are not the only ones who have the idea of using people's cell phones to market something to them, right? And so it seems like people can be sometimes inundated with information.
Right.
And so coordination is really important. And in fact, many countries are now kind of like making it that, I don't know if illegal is the right word, but I think it's illegal to just like do mass texting without getting like proper approval. Because otherwise, like it's like half of it is spam and half of it is and then people don't know what they kind of turn off the whole thing and don't pay any attention. But assuming that there is some sort of coordination and that people who actually are doing type like public service announcement type of messaging or information messaging that are validated by, let's say, the Ministry of Health, using a short code or something that makes them recognizable. There's really a lot that can be done, and a lot of research has suggested that text messaging, for example, can be very helpful to remind people of key, vaccination that they are supposed to bring their children for.
Yeah, the text message reminders would be very interesting.
Yeah, key appointments. And then there's also another technology called IVR, interactive voice response, which can be used to kind of like provide a little bit more nuance and like get people to, you can do some training when you have people like, you quiz them and then they answer, the answer that they think is correct. Like if you think yes, press 1. If you think 2, press no. If you think no, press 2. You can do that even with a dumb phone. You don't actually need a smartphone for that. And then if people said no when the answer is yes, and you can have the voice say, well, actually, and so this type of training where people learn from having thought about it, made a mistake, and then hear the correct response. And so that's another, highly, promising avenue to provide information/training that cell phones make possible. But again, it's really the key is that, well, we could do that for everything. Like I've done IVR to do financial literacy training, for example, for people to make sure they don't get ripped off by, loan sharks, in Malawi. So in every domain, you can think of ways to communicate information. So it's important to kind of like think hard about, well, when is it too much, and people just stop.
And also in these days where misinformation can.
Yeah,
Yes,
exactly.
exactly.
It's
Yeah.
so much.
So we have a couple minutes left. I just, in like 30 seconds or so, one of the uses of these our seminars is to basically alert donors who want to make help. Where would the best uses of a resource to your program, each individual group, would be best? Where would you put it? So Bert, what would you think, Bert and Anna?
I would think that we should put this to essentially carry out the commercialization effort and get this into the hands of physicians that then can take it for diagnostic purposes, learn from the use of it, and accelerate the process of getting this approved for use first in the US and then around the world.
Great. And Pascaline?
So for me, I think one because I work in global health, and there is just a dearth of researchers who come themselves from the global south, and especially women. And so I was very happy to be able to work on this with a postdoc who came to Stanford for a while, and I'm trying to like hire also kind of like pre-docs and train, kind of like contribute to this pipeline of training the next generation of researchers so that they don't, look like me and look, much more diverse. And so I think having that ability to, bring in students and trainees and diversify the pipeline of scholars working on these issues is very important, and funding for that is always welcome.
Awesome. And I'll just point out again, the DRIVE program, which have mentors like, for example, Pascaline, could be very useful for furthering this project. So for those that are watching and who will watch in the future, please apply. The deadline is January 22nd. So.
And Tony, can I make one comment?
Please.
About where I would like to see some of the money go is one of the areas that we are pivoting towards is climate and planetary health.
Yep.
And climate and these extreme weather events impact children, and they're very vulnerable to this. So
yes, that
would be, for us to have more money to give seed grants in this area would obviously, and draw upon the talent that you just heard. I mean, we have a great deal of
fabulous.
at Stanford.
Well, with that, thank you. I think that's an amazing as well, and a worthy cause. And so thank you very much really for highlighting this amazing program around the world. And thanks everybody for joining us. Thanks to the speakers and Dr. Berry. Thanks for joining us. And we'll see you next month on January 10th. So have a great day.
Our pleasure.
So much. Bye.
Thank you all. Bye-bye.
And